Good afternoon and welcome to today's virtual training of DCF private training using the ASAM Criteria for Adolescents as a guide to assessment, treatment, and placement with Marc J. Fishman, MD, presented by the Connecticut Women's Consortium. Funding for this event is made possible by CT Department of Children and Families with federal support from the SAMHSA/CSAT grant number T108088. I'm now pleased to introduce to you our trainer today. Marc Fishman, MD, is an addiction psychiatrist and leads Maryland Treatment Center/Mountain Manor, a regional behavioral healthcare provider, which offers programs for residential and outpatient SUD and co-occurring treatment for youth and adults. He is a member of the psychiatry facility at Johns Hopkins University School of Medicine. His academic and research work has focused on addiction and pharmacotherapy models for care for youth, particularly with OUD, and treatment placement and matching strategies. Dr. Fishman served as a co-editor for the most recent editions of the ASAM Criteria for the treatment of substance-related disorders. He served as a past president 2010 to 2012 of the Maryland Society of Addiction Medicine and is a current member of its board. And here is Marc.
Hi, everybody. Good afternoon. Thanks for joining. And we'll launch right in. So we're going to talk today about the ASAM criteria, the American Society for Addiction Medicine criteria, with a focus on its use in adolescents and youth, also including young adults, but primarily for adolescent treatment, as that's a distinction that's made in most systems and the distinction made in the book. Here are measures. I hope they don't bias me, but you'll be the judge of that. And here's what we're going to talk about today. It's a big topic, so today will be an overview. We won't have time to go into an enormous amount of depth, but the idea being that as the state of Connecticut is adopting ASAM for youth to give people an overview and a basis for getting some familiarity and practice and a deeper dive in the. So we'll organize the conversation today into just a little bit of background about the criteria, but I assume that most of you have some familiarity with the basic ideas from work with adults. Then we'll spend a little bit, about half the time, going over an introduction or an overview to using the ASAM criteria 6 assessment dimensions as a roadmap for assessment and treatment, and give you some examples in each of the 6 assessment dimensions for some particular ways that youth substance use disorders can be assessed, and that those assessment needs can be met through treatment matching with the approach of the ASAM criteria, and then spend the second half illustrating some of those points with a case and some alternate scenarios about modifying the case, and see how that modifies our ideas about treatment and in particular level of care placement. So brief overview, as I'm sure you know, the ASAM criteria has a number of different purposes. One is to guide the field with an approach to systematic assessment, and the criteria uses these particular 6 assessment dimensions by consensus. Are they the best? I don't know. Could there be 5? Could there be 7? I'm sure there's other schemes, but these with long use have kind of sorted out as a nice way that people generally agree is a way of organizing a systematic assessment into particular domains, assessment dimensions, that give us footholds and handholds, if you will, in order to organize that material after you've gathered it from a patient or a patient and their family, and then use it to give us a sense of what the particular treatment needs are. Another function of the ASAM criteria is exactly that, being able to go from elements of clinical severity from an assessment to then determining, well, what are the treatment needs that any particular patient might need based on that assessment of severity as broken down in the categories of these particular assessment dimensions. A nice way of organizing it and giving you a systematic approach to treatment matching. A person has this severity in this particular dimension, and then what do you think we ought to do about it? And then the final function is using that match, if you will, from assessment severity to treatment need to a level of care decision about matching where a person should go to receive the particular treatment determined by that overall analysis. So these 6 dimensions: intoxication withdrawal potential, biomedical conditions, emotional, behavioral, cognitive, or co-occurring conditions, readiness to change, relapse, continued use and continued problem potential, and recovery environment. Here are the way that the ASAM criteria, by the way, you guys probably know that at one point we called the ASAM criteria the patient placement criteria, the PPC, because the common usage was the ASAM criteria. That name has kind of drifted away, but also to emphasize that it's not just about placement. That's certainly one of the functions, but it's also about the meat and potatoes of treatment matching and deciding about treatment planning. Anyway, here are the adolescent levels of care that you're familiar with, from the least intensive of early intervention and outpatient to the most intensive of medically monitored high intensity residential inpatient or rehab and hospital level care. And then, as you know, putting those things together, looking at the assessment dimensions across the vertical axis on the left in red and the treatment levels of care across the horizontal axis at the top in blue. This is a overall oversimplified summary of a treatment matching placement grid in which the idea is to measure treatment needs and severity in each of the 6 assessment dimensions and use that to try to find out where a person ought to go, a particular adolescent that you're assessing, what's the best treatment matching, what's the best level of care placement. And you know, that's what the several hundred pages of the book gets into in detail, but here is just a quick cartoon of that idea. As you know, the book is got both adult material and adolescent material. It used to be divided into 2 separate sections. In addition, those sections are really mostly integrated, and you read along and see along the way where there are adolescent-specific materials that might be different or differentiate from adult clinical materials in call-out boxes along the way. All right, so there's an overview. I'm familiar to most of you, but now I want to get specific about some of the details for adolescents, and I want to go through each of the assessment dimensions 1 through 6 and illustrate just some select greatest hits, if you will, about some of the elements that both are important points of what you should be assessing for and how those might impact in terms of treatment approaches. Now, I said I'd do 1 through 6, but here I have 4. I'm going to start out of order, and I'll tell you why. Part of the reason it makes sense to start with dimension 1, intoxication withdrawal, is from a triage point of view. Let's say you're seeing a patient for the first time in an emergency department, an initial evaluation. And one of the things you have to do right away is decide whether this person is in imminent from withdrawal or from intoxication. So you want to make a quick decision in dimension 1. You know, do you have to admit him to a hospital? Do you have to ship him off urgently? Do you need to call an AMBO? Is there big trouble here? And so in that sense, that's in an evolution, historical evolution, why that might be considered number 1. But for most of us, those aren't the kinds of patients we're seeing day to day, where we're making these kind of quick life and death decisions in an emergency department. We are seeing patients that are clinically referred to us, typically in an outpatient setting. It's not life or death, and that certainly we need to be mindful of those potential issues. But really, where we mostly start with patients is in establishing therapeutic alliance and trying to engage someone. And this kind of engagement, readiness to change, intro to treatment material is in dimension 4. So I start out of order with dimension 4 just as a way of emphasizing that this is where we start with most patients, whether we know it or not. So just some elements, as I said, when a young person meets you and you're asking them about their clinical condition and you're trying to do an assessment and figure out what their story is and what they need and where they should go, we have in mind as clinicians that we're evaluating for problem substance use and the likely possibility, since they've been referred to us as providers, the likely possibility that they have an SUD, that is impairment in primary life function domains because of their substance use. And our idea, not surprisingly, is that these are long-term problems that need long-term solutions, that we want to help improve their function, which has been impaired by substance use, and that the answer to that puzzle, to the extent that we see it as a puzzle, is they'd do better if they were abstinent from substances, and we'd like to promote their journey into recovery. But is that what they think? Not at all, right? They've been dragged in by the scruff of their neck by some meddling adult whose idea it is that they're in trouble, and they don't think that they have a problem with substances. And abstinence and recovery are typically the farthest things from their minds. You guys know this. They want crisis relief. They're thinking, well, do you have better drugs for me so I don't get in trouble? I'll sign up for that. They'd like to be comfortable and not in trouble with that meddling adult. And they'd like you to help them get that adult off their back. Is that their mom? Is that their coach? Is that their probation officer? Is that their teacher? Is that, whatever it is? And not that they're in trouble, or if they are in trouble, they don't connect the dots and see anything to do with drugs. And so it's very important in a dimension 4 assessment to be explicitly understanding about this, right? To not be surprised that they're not all in from Jump Street about abstinence and recovery. Far from it, right? And another thing that's very important is to try to get an understanding of why they're here today. And some of that you're going to get from the young person themselves, but a lot of it you're going to get from some referring adult. Is it a clinician, as I said? Is it a teacher? Is it a parent, et cetera, et cetera? And we want to understand their version of it. Certainly, if we have an objective third party, they're going to be more understanding, and their version might be closer to what our synthetic and analytical interpretation will be. But we also want to emphasize the patient's version. If it were an adult, and those of you who've worked with adults know that one of the things you hear again and again, why did you come to treatment today? I'm tired of being sick and tired. Well, that may not be very helpful, but in terms of getting to the details, but it expresses a frustration with the accumulated difficulties of substances. That's not likely the kinds of things you're going to hear from young people. Again, they're going to connect those dots, and they're going to say, because I got in trouble, and because some adult has the wrong idea. They don't get it. They think that I did such and such or have this problem. But one way or the other, it's critical to try to understand what motivates that person to be here today. And if it is a particular adult that has influence and persuasion in their lives, or that they care about, we want to understand how that motivates them. They want to play on the football team and coach won't let them play. They're in trouble with their parents and they'd rather not be in trouble with their parents. They're in trouble with the juvenile justice system and they'd rather not. Whatever it is, understanding something motivates them, and again, likely not to be connected in their mind to a real problem with substances, but understanding that because it got them in the door. And knowing what got them in the door today is a well that you can return to as motivation waxes and wanes. And as you create a therapeutic alliance, trying to put your arm around the shoulder of this young person and say, well, wouldn't it be great if we could get you out of trouble? with your mom, your teacher, your probation officer. And if I can help you with that, that's a way of cementing our engagement and the therapeutic alliance. And if it turns out that the way to get them off your back is, by the way, to have negative urine screens, well, what a coincidence, and so much the better, and let's work at that. But that's a long view, right? And so in treatment engagement and in terms of understanding levels of severity for treatment engagement dimension 4, things like treatment readiness are the rulers. And you guys are experts in motivational enhancement and motivational interviewing. And, you know, the key principle of meeting the patients where they are not at the door ready to work towards recovery. So the idea is that they might need discovery rather than recovery as a primary focus of treatment. And rather than jumping to the idea that they might need rehab or residential treatment, maybe they need preparation for rehab in order to make that go. Those aren't the only two tensions and the only two considerations, but I just bring them to you as illustrations of those points. And you guys know the stages of change, and just important to remember that it's a rookie mistake, as I'm to expect that a young person presenting for an evaluation is going to be in action phase, right? They are not looking for help necessarily with abstinence and recovery. Mostly they're in contemplation at best, but usually pre-contemplation, and perhaps more often in pre-contemplation, at least the patients I see. And so be that and understand induction, progressive treatment engagement, and use of MI and MET for progressive progression through these stages of change over a longer period of time is the work that you're going to have to do. The motivational approaches that you'll use are things that if you're working with adolescents, you know about. They're going to say, when you first ask them, are you in trouble with drugs? They'll say either, oh, well, I don't use drugs, I don't know what you're talking about, or sure, I use drugs, but it's no problem. It's the mistake of some meddling adult that thinks it's a problem. I'm not in trouble. Well, okay, fine. Rather than go up the middle and have a fight about that, these are ways of perhaps doing an end around. So you don't have a problem, but do you know other kids who do have a problem? And that's a way of making them less defensive and probably talking about other experiences they might have had. And then at least you've got on the table the notion that there could be an amount of drugs that's too much, but we can discuss it in terms of somebody else. Or if you're not in trouble now, what would be a line that if you crossed would be too much? And again, another way of just having it on the table that there could be such a line and that we know what that is. And these are those kinds of conversations, you know, that I'm sure you've learned how to have, but it's important to be explicit that it's not about getting into an argument. It's about trying to gradually increase a evolutionary and organic change in motivation over time, and that's the way motivation changes. Part of what we have to do as clinicians who treat adolescent substance use is learn to be here like Ratson, the king of salespersons, selling refrigerators to the Eskimos. It's not easy, but we are used car salesmen in a sense, trying to convince a bunch of teenagers that they shouldn't be using substance. And we're not surprised that it doesn't work and there isn't a big epiphany with the scales falling from their eyes with a blinding bolt of lightning the first time we talk with them. No surprise to you guys. All right, that's dimension 4, just in a quick, brief overview. Now let's go back in order and start with dimension 1, intoxication withdrawal potential. And here are just some examples of some of the things that you might commonly see with adolescents. The most common substance for which adolescents are referred to treatment is cannabis, followed by alcohol. And they use a lot of nicotine as well, but they're not off treatment for that. So important to know about cannabis withdrawal. It doesn't require hospitalization. It isn't dangerous or life-threatening. Alcohol withdrawal is, but it's a thing. And it's important that you know about it. It's important that it's taken into consideration at any level of care. And some of the prominent features are insomnia, irritability, but you can also have GI upset and temperature dysregulation. With marijuana intoxication, you don't expect a full cognitive function at a person's baseline, likely short-term memory problems, thinking problems, etc. Although we don't see a lot of alcohol withdrawal in younger people, they haven't been drinking for long enough. Physiological opioid withdrawal is very quick in a young person using opioids regularly. In as short a time as a couple or 3 months of regular use of opioids. And so, although most of your young people won't be opiate addicted, some will. And so knowing about opioid withdrawal and the physical sickness that comes with it and the severe craving states that come with it, and knowing about its treatment, what's the best setting for that, what are the best treatments, and where they are best done. Any intoxication, especially most commonly for young people, cannabis can cause agitation, can cause psychosis. Inhalants, we don't see a lot of. When we do, we see lots of cognitive problems. If cocaine or methamphetamine is a big thing in your clinical cohort of adolescents, you're not surprised to see a lot of depression, a lot of severe craving. And for the subgroup of people that use hallucinogens, there's all sorts of persisting perceptual distortions or flashbacks that can be a problem. But the idea is you're knowing what the common classes of substances that are used by the adolescents in your area, and you have a sense of where these are best treated depending on the severity of the person in front of you. For opioid withdrawal, we know that medicines are available for treatment, often of withdrawal, and for transition, as we'll talk about in Dimension 5, for ongoing relapse prevention. Oftentimes, most often, I think it's appropriate to put adolescents with opioid withdrawal in bed-based care. There's very little information about the success of ambulatory detoxification for adolescents in outpatient treatment. Alcohol withdrawal is very dangerous in young people, but it's infrequent. But when you do see it, that's usually an indication for bed-based care to be able to get the both high dose of monitoring and treatment and the presence of medical personnel 24/7. As I said, with cannabis withdrawal, attention to insomnia is very important, and one of the things that we can treat easily at all levels of care, including the outpatient. And one of the things that I like to say about withdrawal management or detoxification is even if you don't need a medical approach for safety in withdrawal management, you do need a major behavioral intervention that leads to discontinuation of an ingrained habit. That's difficult for anybody. If you've been using something a lot, if you've been using something every day, just changing that habit, even if it's not physiologically dangerous, is a big deal. Not that you need to be in a hospital to do it, but that we as clinicians need to make that an explicit goal and need to debrief that with patients. And that we as counselors and therapists need to understand that we're asking a lot of people to change the momentum of a deeply ingrained behavioral habit. Detox can be a revolving. We see this more in adults than we do in young people, but there is a high severity cohort of adolescents who've had more than one detox admission, say for heroin or fentanyl. But the idea is that it should lead someplace. So detox alone, although it may be necessary for substances, particularly say opioids, detox is never sufficient. And so the idea is that the levels of care that include withdrawal management ought to be intrinsically linked to ongoing care, whether that's residential rehab, whether that's intensive outpatient, whether that's outpatient. That is an explicit link that is critical. All right, Dimension 2, biomedical conditions and complications. This is going to be an area that is less typically salient for young people than it is for your older patients. Those of you who've treated older adults see a lot of this. And it's primarily for two reasons. One is because they haven't been using as long to accumulate as many road miles on them and be beat up by the medical consequence of drug use. And the other issue is that as young people, they're usually relatively healthy. They haven't accumulated the miscellaneous health conditions that any of us, drug use or not, get with older age, but that are exacerbated by substance use and by chaotic lives with the neglect of ongoing health maintenance care. So it's not going to be as big a deal in younger people, but that doesn't mean it's a zero deal. And so just to remind you, one of the neglect areas in young people where there can be a serious overlap with Dimension 2 is traumatic injuries. Young people get intoxicated and they get into car crashes. They fall off ladders. They dive into swimming pools without any water. They do a variety of dangerous and knuckleheaded things while intoxicated on any substance that can get them into trouble. And it is something that is sometimes neglected in an emergency department where somebody is being evaluated for a traumatic injury, neglected connecting the dot to the intoxication and an associated substance use disorder. Seizures, relatively rare as a manifestation of benzo or alcohol withdrawal, but when it does happen, it's certainly a marker of high severity. Injection drug use and the transmission of HIV, hepatitis B and hepatitis C, and soft tissue infections from injection use, again, not as common, but certainly not rare. And overdose, and with the opioid epidemic of the past couple of decades, we've seen a very tragic increase in opioid overdoses, mostly non-fatal, but some of them, again, tragically fatal in adolescents. And if we can identify the preliminary warning signs of that, that is a non-fatal overdose, that is predictive, as you might imagine, of trouble. And the data in terms of detection is really alarmingly poor. When you look at case identification from an opioid overdose and entry into treatment with relapse prevention medications, or MAT, we do an alarmingly poor job there. And that's certainly an area in which there's much potential room for improvement. But I will say that you sometimes don't get a second chance, and that's quite tragic. There are far too many cases of first presentation of awareness to a family of a problem with opioid addiction to have a near fatal or even fatal opioid overdose. And of course, that's a very, very sad thing when it happens. Just some other conditions that aren't as serious, but just to keep in mind, is that have asthma, and that's exacerbated by smoking cannabis, sexual behavior that is not regulated well, in which patients are not using barrier contraception methods and might get a variety of STIs. Pregnancy, although not itself a pathological condition, can be, again, of disinhibited sexual behavior in intoxicated young people, and on and on. All right, Dimension 3. This is an area that I know many of you are very concerned with, and it's one that is very critical in young people because of the high frequency and prevalence of co-occurring disorders, co-occurring psychiatric disorders in young people. And here's a picture of why that shouldn't be so surprising. On the one hand, you see the population prevalence of tobacco use, THC or cannabis use, and alcohol use across the lifespan. And as I'm sure you know, most people initiate these substances and all substances in the middle of the second decade of life or early in the second decade of life, that is in adolescence. And then peak prevalence is at the end of the second decade of life or the beginning of the third decade of life, that is in young adulthood. It's not that there aren't plenty of people on the right-hand side of the curve, that is older adults who have substance use, but when did they start, right? This is a substance use disorder, is a developmental disorder of pediatric onset, right? Think about that. So adolescents are really at the core of the SUD epidemic, but it's also important to remember that half psychiatric disorders have onset before age 15, and 3/4 of psychiatric disorders have onset before age 24. So it's a very similar time span for when people develop SUDs or develop psychiatric disorders. So even if they're not causally linked, and you guys know sometimes they are, just by chronological natural course of age of onset, it isn't surprising that they travel together a lot. So we're not surprised when a young person has both an SUD or several SUDs and a co-occurring psychiatric disorder or several co-occurring psychiatric disorders, right? So high prevalence of comorbidity, we should expect and suspect co-occurring psychiatric disorders. They will come in the flavor of psychiatric disorders that came on before SUD and can be a vulnerability for the development of an SUD. They can be a disorder that came on after an SUD and maybe be caused by the toxic effects of a substance. More often, we see them intermixed in a way that's hard to dissect out, and we can't tell which came first, the chicken or the egg. But that's okay, because when we can tell the difference, it may be instructive, it may guide us into a particular path of treatment, but more often than not, we can't tell. And what's the response? It's to treat both in as integrated a way as we can. And I'll show you some data in a second that tells us about outcomes there. And so because the rates of these disorders are so high in young people, because they will be so common in their co-occurrence in your SUD adolescent patients, it becomes part and parcel of what we do as SUD treatment providers to either directly treat their mental health conditions, or if that's not in the scope of our practices or our agency, to at least have close associations and referral interactions where we can coordinate that treatment with other providers and collaborate on that treatment. You can tell I'm a Gary Larson fan. Here's the psychiatric view of our patients. The shrink is talking to an adolescent substance user and writes the diagnosis, just plain nuts. Hopefully we can do better than that. The idea being that we want to be able to go into this in some depth as we get to know a patient. Maybe it's not going to be on the first day's assessment, but try to tease out what treatments in particular will help sustain the person's recovery and do concurrent, not sequential, but do concurrent treatment of both the substance problem and the psychiatric problem. Here are some domains that are important in assessing co-occurring psychiatric disorders. The one that we know the most about and is something that is a triage issue is imminent danger. Is a person suicidal? Is a person homicidal? Is a person at risk of danger from being a victim, either because of the situations of risk that they put themselves in while intoxicated or because of ongoing abuse and neglect, et cetera, et cetera. But some of the things that we don't think of much but are very critical include interference with recovery efforts. That is, how do symptoms of a co-occurring psychiatric disorder make SUD treatment less digestible, less easy for the person to participate in, absorb? The social functioning role of an adolescent, school, family, work, relationships. How is it that both the SUD and the co-occurring psychiatric disorder impair their activities of self-care, and affect the overall course of illness? Course of illness is an important domain because it reminds us that past behavior, past trajectory will often predict future trajectory. Not 100% of the time, but it's a good starting place. And by that I mean, how did a person's course of progression go before? That is, if they relapse on cannabis use, are they a person, if they have a co-occurring depression, a co-occurring psychosis, does their psychiatric disorder deteriorate right away or not for another 6 months? If they stop their antidepressant for their major depression, do they tend to relapse right away or not for another 6 months? And what about treatment response? Did they have a good response to a particular kind of treatment if they've had treatment before? Great, let's do that again. Did they not have a particularly good response last time around if they had a previous treatment? No, let's try something different. Here's some data that reminds us of the severity of the interaction or the impact of the interaction. As an example, depression and SUD. We see that if you look at rates of initiating alcohol on the left or illicit drugs on the right, that having had MDE, that is major depressive episode in the past year, either doubles or triples your likelihood of initiating substances. Here, it doesn't tell us chicken or egg which came first, but it does tell us that they're intricately linked. Here's some treatment outcome data. This is dividing patients in terms of depressive symptoms, Beck depression inventory, high or low, blue meaning high, red meaning low scores at admission to residential substance use treatment, and then looking at the number of substance using days, that is their level of severity over the ensuing 12 months. Everybody comes into residential treatment with near daily use, right? That's kind of a severity criteria. People get better with treatment, and then back out in the community, they tend to relapse as they're not in continuing care. They're back in their toxic neighborhoods with peers and other places where there's use. But those that have higher depression do not respond to treatment as well and relapse more. Again, a reminder that doing something about co-occurring disorders is vital to the success of SUD. And here's some treatment outcome data. This comes from a study by the University of Colorado group led by Paula Riggs, looking at treatment for adolescents with depression and active SUD. One thing it tells us is that you can treat actively using adolescents with both psychotherapy and medicines, and it's a safe thing to do in terms of concurrent integrated treatment. And what it here is looking at SUD outcome responses, that is days of use over time, based on whose depression scores got better. That is, who was a responder versus whose depression scores didn't get better, non-responders. And whether those responders were people who got medicine or psychotherapy or both wasn't the thing that mattered. Both were good treatment approaches, but what mattered was whether their depression got better. And those whose depression got better are those whose substance use got better. Vice versa, those whose substance use got better are those whose depression got better. So you shouldn't be shocked to see that those two disorders improve in a coordinated fashion together. And you're not shocked that if the depression's not responding, the substance use is not responding, and vice versa. You don't expect the substance use to melt away by treating the depression. You have to treat both. All right, dimension 5. This is the relapse potential, problem potential dimension. And here is just an overview of some of the things that you're interested in asking. What particular drugs, what pattern, what frequency, how has that changed over time? What do the drugs do for you? Pos and neg. What kinds of triggers have you had, both in terms of internal stressors and external persons, places, and things? And what are aspects of a person's developmental vulnerability in an immature adolescent that you can expect give them likely either assets in terms of being able to promote recovery, or more likely vulnerabilities that make it more difficult, their sense of invincibility, your knowledge of their immaturity, your notion of them having poor coping skills. And you're not surprised because they have less life experience than a corresponding adult. We build in role induction about lapse and relapse. That is, relapse is an part of the course. It's not that we encourage that, hey, it'll be okay if you relapse, don't worry about it. Of course, we want people to not relapse, but we expect that many will. And that's not a personal or treatment failure. We want to encourage honest reporting. And as things work or don't work, we want to debrief about those things and incorporate changes into the treatment plan based on that. Dimension 6 is a very important one for young people because young people are embedded in the support of caring adults, or at least so we hope, right? So the family influences are critical, and they can be both positive and negative. That includes family drug use, family attitudes towards drug use, broad family values towards pro-social stances and behaviors. And we want to bring in families as best we can. We talk a lot about addiction as a family disease, but mostly we pay lip service to that and don't do, I think, a good enough job to work actively to bring families in. We have to think about what substances might be used in the household, by peers, in communities. Those are all factors. We need to think about what families are capable of adding or detracting from the treatment. Can they provide active support by learning to do a better job at supervision and monitoring, or at least being on the sideline with enthusiasm and cheerleading? Technical, practical assistance with transportation, with paying for treatment, with participating in family programs, with scheduling, those kinds of simple but critical practical issues. There may be families that don't have that active support capacity, but at least are neutral and willing to let you do your stuff. And then there are families that are either openly oppositional or passively undermining, and we have to work hard to account for that. The culture we live in is a critical issue for our adolescents. Lots of families will say, we did it when we were kids. We should learn them how to smoke and drink at home where they can learn responsibly. You and I know that that's fallacious, but it is an attitude that's out there. And so we have to think about the water that the kids swim in, which is a culture that glorifies intoxication and its trappings. And all you have to do is turn on AM radio and hear the latest hits talking about, how great it is to be at a grand party supported by all the pop stars and music stars, movie stars, raising a glass or raising a blunt like Snoop does, and all kind of stuff is something that the kids breathe, and we have to understand is a major cultural influence that's hard for us to counter, but it's part of what we do. The idea of substance-using parents is a sticky wicket, because the parents didn't come here for you to tell them what to do, and they're going to say to you, well, that's none of your business, and I don't have a problem, and how dare you? So we're always a little, well, how do we manage that if we have a hint, or even if we have direct knowledge that there's use in the home? So just one approach to this that I like is what I call my universal precautions approach, which is just to say, listen, I don't know you, I just met you. I'm not saying you have a problem. I'm not even saying you use, but some families, there is normative social drinking or normative social smoking or cannabis use or whatever you do. Privacy of your home, it's none of my business. If we're trying to get Junior to use, they're mimics. They do what you do, not what you say. I know it's asking a lot, and I'm reluctant even to say anything, but creating a substance-free home, at least temporarily, like while we're trying to get Junior to quit, can be a help. Can you go there with me? For a while, it's not forever. Sometimes that's helpful. Other times they punch you in the nose because they think you're criticizing them and you haven't gotten anywhere, but it's one approach. This is not a parenting practice that is very effective, right? The authoritarian, I'm going to cut your head off if you use. And we've got to try to encourage parents to be firm, but not punitive. That's hard. All right. I want to switch now to the rest of the discussion, putting some of this stuff into practical use through a case illustration. So let me show you a case of Brittany. She's a 16-year-old young lady referred from probation for evaluation. longstanding cannabis, binge alcohol, and minimal treatment. This is the quick overview. She lives with grandma. She's had poor academic performance and chronic involvement with juvenile justice. She has some problems with attention and irritable, explosive mood, and grandma calls her out of control. Let's look at the details. You do your usual assessment, and what I'm going to do is I'm going to break it down into the details of segments of assessment, the way you might ask the questions. Then I'm going to break it down into the dimensions to look at it using the lens of the 6 ASAM dimensions. Then we're going to talk about what that might mean in terms of placement. And then we'll throw some questions about alternate scenarios. What if the history changed in this way? What if it was this instead of that? And see how that affects our thinking. So, as I said, she's 16. She's referred from probation. Her substance use history is that she began smoking cannabis at 12. That was intermittent and experimental at first, but it progressed to daily by age 15. She began some drinking at age 13, and now she's got a kind of a sporadic but steady weekend binge pattern. She has used methamphetamine once or twice, casual experimentation. It hasn't gone much further than that, although certainly that's bad enough. She was in detention, let's say, but now she's out. So let's take away that she's in detention now, and let's say she's back using. She's had a few sessions of SUD counseling several months ago, or at least was referred to that, but mostly she was no-show, and grandma says we couldn't make her show up. She lives with grandma. Dad's been incarcerated and has little contact. Mother is unavailable. That's why grandma is in the parental role. There's an allegation of molestation by a neighbor at age 9. We don't know much more about that. She's been sexually active. She's had 8 lifetime partners. She's currently got some partners, engages in unprotected sex. That's more often when she's intoxicated. Poor school performance. She had to repeat the 3rd grade. Somebody once said to her she was a slow learner, but we don't know the specifics. We don't have access to testing. She has not received formal special education services. Suspended from school, disruptive behavior. She's supposed to be in 10th grade, but she mostly hasn't been going this year. And most of her peers and her close acquaintances and friends are drug involved or delinquent behavior involved or juvenile involved as she is. Asthma, she's got at least one known bout of chlamydia for which she's been treated. She had a pregnancy and then a spontaneous abortion or miscarriage. She's got some complaint of chronic stomach aches, but we don't have access to any knowledge of medical treatment or what that's all about. She's had an arrest for CDS possession on school grounds at age 14. The charges were dropped. She got into a fight and was arrested and received probation for that. She's been on house arrest this past year on a CDS charge for intent to distribute. And then she was in detention, let's say, where her probation was violated because she used grandma's car, unauthorized use of a vehicle, used grandma's car without permission, and grandma attempted to press charges, and now she's violated, and that's part of the referral to you. Psychiatrically, she's not in treatment necessarily and doesn't have a known diagnosis, but she's had this problem with inattention and hyperactivity, never been treated, chronic emotional lability and irritable mood and tantrums from an early age. That's been worse since her substance use has been initiated and progressed. Grandma says she can't control her at home. She stays out late, and at least once she stayed out all night. She complains of insomnia, and her sleep-wake cycle is disrupted. That is, she stays up all night carrying on, and then she sleeps in and doesn't go to school. She says cannabis helps her chill and makes her more mellow, and she's less likely to fight with her peers if she's smoking. It's the only thing that helps me, doctor. Don't you understand? You've heard that before, I know. And that's her story. The school has tried to refer her to counseling, but that's never gone anyplace. She's never had a formal psychiatric evaluation. And when she doesn't use cannabis, her insomnia and irritability at least gets temporary. So what are we going to make of her? What are some of the high priority treatment goals here? How do you sequence when you bring her into your treatment program, into your solo practice, into your IOP, wherever it is? And let's think about the appropriate placement for her in addition. So here's some questions. Which of the following statement best describes appropriate treatment placement strategy for Brittany? And we don't have time. I'm not going to read each of these, but I want you to look at these as possible options. And there's no one right answer in some of these questions that I'm going to show you over the course of our discussion. I mean, some of them might be not so helpful, but I think that they are discussion points for us to say, what's the kind of additional information I might need to decide if option 1, 2, 3, 4, 6, 7 are things. I've given you a little bit of history, but there's clearly stuff I haven't told you. There's more assessment that can be known, more detail that will come out as you get to know this young lady better. So part of the question as you make determinations is, what else would I want to know? How would I have to see how she responds to be able to answer that? So one possibility is you could say, well, listen, she's in probation. She ought to be in detention. She ought to be locked up where she can be kept safe and have some kind of juvenile justice mandated behind the walls treatment. I don't know if that exists in your state. It does exist in many states. Is it a good idea? Some people might say that such programming is effective. It's certainly highly restrictive. And would I say that automatically somebody should be locked up for? I'd say no. Should she automatically go into residential treatment because she's high risk and in imminent danger of harm today, tomorrow? Well, let's talk more about that when we get to the placement discussion. Maybe she should be in a level 1 program because she's clearly not motivated to do anything else. So maybe she needs to be in prehab, in discovery rather than recovery, and let her have low intensity services until she gets more motivation. Maybe you'd put her in a level 2 intensive outpatient program, or maybe she should be in a drug court program if those exist. I don't know the answer, but these are the kinds of conversations that we should be having about this material. What are the priorities? Where are you going to start? There's a lot of stuff you need to do for Brittany. You can't do it all on the same moment. So where do you want to start? Do you want to get her to admit that her cannabis use is out of control and self-destructive? Do you want to build therapeutic alliance by offering to get her out of trouble? Do you want to jump right into the trauma that you might think is the underlying cause for her troubles? Do you want to help her address her cannabis withdrawal, which you might think is part of her irritability and insomnia? Well, one thing I would say is that 1 is not appropriate, right? She doesn't think that her cannabis use is out of control, and she doesn't make the connection between her cannabis use and her problems. That doesn't surprise her. So I wouldn't put a lot of emphasis on getting her to insight. Insight, if it comes, is a long-term goal. That's not today. And I would reject number 3. We don't have evidence that her trauma is the most important thing, and trauma is not an appropriate way to start. But I would say that 2 is a possibility. You want to build therapeutic alliance, and how can you do that? By trying to align with whatever her motivation is. We don't know that yet, if she has any, or by offering to align with her desire to get out of trouble, which I suspect she might have. And if she does find her cannabis withdrawal to be a problem, even if she doesn't label it as such, you might win some engagement points there. So those are possible. All right, let's go over dimension by dimension, putting the assessment material that we've gotten, and I presented to you, now organize it by the dimensions, right? So what's she got going on in dimension 1, acute intoxication or withdrawal potential? Well, I think she does have cannabis withdrawal. And when she doesn't smoke, she has trouble with sleeping that's worse than usual, and she has trouble with irritability that's worse than usual. And what are you going to do about it? Well, I think it's helpful to teach her about that if she's open to it. I think it's helpful to talk to her about sleep hygiene. That is, if you can get up in the morning and go to sleep at night and train your body for regular sleep patterns, that's helpful. It's good luck trying to teach that to a teenager, a normal teenager, never mind a teenager who's addicted to cannabis, but it is an important seed to plant. And one piece of low-hanging fruit that if you have medical services available in your program is to consider a mild temporary sleep aid, whether that's chamomile tea, which is pretty darn mild, or whether it's over-the-counter Benadryl, like, NyQuil sleeping aid, or whether it's even something like low-dose trazodone and a variety of other non-habit-forming sleep medicines. That gets you a treatment advantage that if you can help a person sleep right away, you get some engagement points because, look, you've accomplished something. You've gotten them to a doctor who can help them sleep. The doctor's given them a tool that they notice right away. And the other thing is, it's an enormous relapse trigger. If you're used to smoking at bedtime in order to sleep, it's very hard to stop. But if you can have a substitute approach, that can be helpful. But anyway, doing any of those things could be done at any level of care, right? That doesn't force your level of care placement decision. You could do these kinds of things about her mild withdrawal. It's not alcohol withdrawal, doesn't put her in danger. It's not opioid. It doesn't need medical withdrawal management and detox, doesn't require any particular decision about placement. It can be done wherever you place her, from outpatient to residential to wherever you go. So that doesn't really affect our level of care decision. What about dimension 2? Well, she doesn't have any acute problems. She had some chronic problems, right? She's got these stomach aches. She's got this asthma. She probably needs STD screening because we know she's having indiscriminate sexual behavior and has had an STI in the past. She probably needs contraception services. None of those are emergencies. None of those require bed-based care to implement. So again, you could do those things at any level of care. And this isn't the dimension that forces your level of care placement decision-making, right? Dimension 3, all right, now there's a lot going on here. She's got very significant mood disturbance. She hasn't been evaluated. Now, she's not in imminent danger, right? She's not jumping off a bridge. She's not about to kill anybody, but her social functioning is very significantly impaired, right? School, legal, and family are all social functioning domains that are very impaired in this. She's not succeeding, prospering, progressing in the so-called jobs that a young person at her stage is supposed to be doing better at. And you can imagine that all of those emotional behavioral symptoms have the potential to significantly impede her SUD recovery efforts. She's not cooperative. She hasn't been cooperative in the past. She's got some runaway. She's not cooperative with grandma's rules and being able to organize a household. You wonder whether she'd been able to be cooperative with your treatment schedule. You wonder about that. And you see that one aspect of self-care, that is her ongoing sexual risk behaviors, is also impaired by repeated intoxication. So here's an area that has some needs. The first thing she needs is an evaluation, right? We don't know what psychiatric, co-occurring psychiatric condition she has, but we sure would like to have that evaluated. Does she need treatment for depression? Does she need treatment for her anxiety? Does she need treatment for her trauma? Does she need treatment for her anger? We would like to get that part of our treatment plan as a high priority. And in order to implement whatever treatment is dictated from that evaluation, we would like a highly structured programmatic treatment setting to make that go. Is it psychotherapy? Is it medicine? Is it both? Whatever it is, you're going to want that closely monitored and some structure around it so that she can continue to participate in that treatment, especially given the history that she's not been particularly cooperative about that and that grandma hasn't been able to make it happen, at least to date. So some level of high intensity or moderately high intensity, something with daily structure and the ability to do close monitoring of behavioral and treatment response. So what should that be? Well, maybe it's intensive outpatient or day program where it's daily or near daily contact, if she'll show up. Or maybe it's level 3 residential placement, especially if you try level 2 intensive outpatient and you don't get the progress, or if you're concerned that the structure at home insufficient to get her to go to day program sessions or 3 or 4 times a week IOP sessions. It depends on what you learn about grandma, depends about what you learn about her response to probationary mandate and that kind of leverage. But you're somewhere in that range. Intensity, maybe it's outpatient, maybe it's low intensity residential, but you're kind of in that bound trying to learn more about what would tip the balance in one direction or another. All right, dimension 4. She's clearly in a pre-contemplative stage of change. She doesn't see herself as having a drug problem. She has a probation officer. And you're a probation officerologist right now trying to help her with that problem. What's the way to do that? Well, you need some kind of programmatic milieu to support progression through the stages of change, at least getting her to contemplative, to think about what a life with reducing drug use might be, to connecting the dots between her current predicament and her drug use. And again, somewhere in that high intensity boundary, it isn't clear that she needs to be in a bed to do that. If she would come to a high intensity structured milieu like an IOP or a day program, she'd probably do fine if she would show up. And that's critical in trying to predict. None of us are mind readers. You can read the future. My crystal ball's rusty. I don't know about yours. So we don't know what will happen, but we make our best predictions about what's the likelihood. And again, we're probably thinking that a level 2 intensive outpatient or day program placement will be adequate for dimension 4, but we're reserving judgment about whether she can actually show up. What about dimension 5? She's had some brief abstinence in the past by confinement, but no real appreciable abstinence otherwise, and certainly no acquisition of recovery skills. She's at very high risk of immediate continued use. In fact, let's say she's been using as recently as yesterday, today. She would not attend a previous referral to outpatient treatment before. So again, here you need a fairly high intensity, near daily or daily structured milieu treatment where you can use such tools as relapse trigger identification, refusal skills rehearsal, pro-social leisure activities, and the use of a pro-social peer group. Not things I think you could easily accomplish just in once a week individual sessions or once a week group sessions. I think you need a higher dose. I think that if she would come, an IOP or day program would be but again, we're wondering, will she come? What about dimension 6? Well, grandma is certainly supportive. She values what you're suggesting. She wants her kid to do well, come to treatment, stop using, get the psychiatric evaluation that you're recommending. But so far, grandma has lacked the personal resources to sustain treatment. Her peer group, which is so important to an adolescent, is predominantly substance using. And so what do we make of that? She needs some kind of family intervention. We know that we want to be able to improve grandma's leverage. We want to improve grandma's ability to manage her at home and make things less chaotic, and to show up for treatment, which we're not sure we given that she's run away before, given that she's sleeping in, that she's not going to school. We've got various examples of how her potential cooperation is poor. We think that we could engage grandma and her to make these treatment interventions and objectives at a level 2 IOP treatment placement. But again, we're concerned, would she show up? So how do we put all that together? What should we do? Before we get to that, so what should we do? I'm on the fence here. I think if you're thinking that based on more detail, because, we've only got so much detail so far, that you think she'd show up, that grandma says I can deliver her, then I would try a level 2 placement, an IOP or a day program. If you think that way and grandma says she's going to run away and it's never going to happen, then you might try low intensity residential. Another approach is to try the level 2 or day program first, but have a low threshold for switching her over. But these are the kinds of considerations that I think inform your placement decision. And the key to placement, as we said before, is where's the place that you can most effectively get the needed list or matrix of needed intervention done? How do you bundle them most effectively as most likely to succeed? Now, what I'd like to do in our remaining time is to go over some alternate scenarios. And what this will do, because as I said, we've got a bunch of information, but only so much information. And thinking about how, if we're on the cusp here, what would some alternate scenarios, or seeing how the case unfolds with time as we start to engage her at one level of care or another, how would that persuade us that we made the right decision or the wrong decision? How would it persuade us to modify the treatment plan, and with that, perhaps modify the level of care placement decision or not? Let's start with the assumption, admit her to a level 2 day program. Everybody has daily or 5-day-a-week day programs. So an alternative, if what you have locally is a 3 or 4 times a week IOP, we could think of that. But let's say we brought her into intensive outpatient treatment to give it a try. But Brittany runs away from home, as she's done before during her first week of the program. Now, what should we do? And I think we have a variety of options. And part of it is thinking through how we get particular information, particular and customized to this person, and modify the treatment plan. And with modifying the treatment plan, maybe we're modifying the level of care placement. So maybe we're saying, right, that's a failure of intensive outpatient treatment. Now let's try to put her in residential treatment. I don't think that violating her probation, let's say the treatment and outpatient treatment was mandated, and jumping to detention is necessarily helpful. I think that's overly punitive and much more likely to put a wrench in the works of her treatment engagement. But let's say she comes back to grandmother's 24 hours later. You might say, let's give it another try. I don't know the magic of how many tries before you cry uncle, but it's not unreasonable to try at least once more. And another possibility is to say, well, what makes her tick, and how can we shape her behavior? Through probationary sanctions, through incentives, through getting grandma to offer certain kinds of home incentives. Some places have progressive sanctions that have short-term detention programs, but often the juvenile justice system is not nimble enough to be able to move in real time that way. So I think that's unlikely. All right, let's say now in an alternative scenario that her psychiatric severity is much higher. You learn that she's been suspicious and she's thinking that other young people are listening in on her. And maybe she's responding to invisible stimuli and talking to herself, or won't answer your questions, saying things like, you're all trying to get me in too deep. I know what you're up to. Well, that really shifts your assessment of her risk in dimension 3, doesn't it? So here, now we're saying she's got very high severity psychiatric co-occurring symptoms. And the urgency of a psychiatric evaluation jumps up really high, doesn't it? Looks like she's got some psychotic features. Maybe we don't know what the diagnosis is. Is it substance-induced psychosis? Is it major depression with psychotic features? Is it incipient first episode schizophrenia? We don't have to know that, but we do know that we better jump on it, right? So does that mean put her in residential treatment if there's adequate level of psychiatric value at your local residential treatment for co-occurring disorders? That might work. Arrange for a psychiatric hospitalization. Yeah, that might be necessary because this is now a very serious psychiatric problem. Number 3, wait and see how she does. I wouldn't do. I think you got to act now. I think that number 4 is a possibility if you've got a psychiatrist in the office who can see her right now. Most programs don't have the luxury of being able to turn that around on a dime, but if you have it, you have it. And number 5, I throw in because some programs will just say, well, that's too tough for us. No, thank you. And I hope at least if he's too severe for your particular program, that before you just say no, you're thinking through with grandma, well, I have some alternate ideas for where you can get help. All right, so let's say you get her this psychiatric evaluation, whether it's in the ED, in the hospital for a week, or your psychiatrist happens to see her if you're lucky enough to have one at your left elbow. And she says, but you know what? I'm not that medicine. I'm not crazy. I don't need any stupid pills. And then she's non-adherent to some recommended treatment. So do you talk with her more about the pros and cons of medication? Do you tell her if she doesn't take the medication, she can't graduate? Do you get grandma involved and see if grandma's got some juice that can make things go? That you at least say, well, fine, we have this tool, we think it'll help you, but if you can't use that tool, then you better use some tool to get yourself together, or else you'll be in a heap of trouble. Or do you tell her, well, you're right, it's not natural, you shouldn't take the pills, we agree with you, we don't agree with the dumb shrink. Anyway, I think that these things illustrate, though, that you can't just pawn it off to some separate psychiatric treatment arm. If the psychiatric treatment is integrated into your program, so much the better, but not that luxury. But whether it's an external psychiatric treatment approach or whether it's baked into your program, it's your business, because she's not going to get better in this circumstance unless she cooperates with the treatment. Again, whether that treatment is medicine or psychotherapy or whatever it is, it's important to the outcome of your SUD treatment. So you want to make it your business, whether it's by leveraging grandma's persuasion, whether it's by convincing her, whether it's by upping the juvenile justice leverage, whatever tools are at your disposal, it becomes an essential part of your treatment plan. All right, so let's say in an alternative scenario, part of the information was that instead of just this one referral once to outpatient treatment that she can go to, she's a person who's had numerous previous started attempts at SUD treatment. She's been in outpatient treatment a half a dozen times. Each time it doesn't go well. Maybe sometimes she doesn't go, other times she does go, but one way or the other, she's been a bit of a revolving door, and you're the 6th evaluation this year, and nothing's working so far. I'm not suggesting be pessimistic, nothing can work. Always have therapeutic optimism, but what should you do different? I think here, this now tips the balance from well, maybe we should give another try at high intensity outpatient and see if we can persuade her to show up. Well, if she hasn't showed up 6 times before, right? What's the definition of insanity? It's trying to do the same thing and expect different results. Maybe now it's time to increase the intensity by referring her to residential treatment, where at least some initial engagement through confinement, not that she can't run away, not that she can't sign out, not that she can't not cooperate, not that she can't be uncooperative, of course, but at least to try something more intensive. And I think that tips us there in that decision making. What about it's no longer that her primary substance is cannabis, as we originally talked about, but now we hear her primary substance is heroin. How does that change things for us? Well, this is primarily a dimension 5 issue, isn't it? We're looking at the types and frequency of substances and what the relapse risk is. It's also a dimension 1 issue. Is she going to need withdrawal management? So now you have a 16-year-old adolescent with heroin use who's going to have withdrawal. I think that's a person who needs medical withdrawal management in bed-based care. Now, it might be that your program has particular sophistication with the initiation of medications for OUD. That's not a common thing, but if you have a program that can do that, it is not unreasonable if you've got the experience with adolescents with OUD, initiating them onto medications like buprenorphine in an outpatient program, and you know how to do that, and that's worked in your hands. You can start buprenorphine as an outpatient. It doesn't often work with adolescents with as much frequency as it does with adults, but it could be worth a try. But in most settings, for me, that's a residential placement decision to get someone started on a medicine like buprenorphine, on a medicine like extended release naltrexone. Now we have extended release buprenorphine as well. So all of those are potential treatment options. And the key is treat, get somebody onto a maintenance relapse prevention medicine in any setting that works. Usually it's a bed-based setting, but as I say, if you happen to be one of the lucky people that's got a program infrastructure that knows how to do that in an ambulatory setting, that's okay too. In an alternative scenario, let's say that her primary substance is not cannabis, it's not heroin, but it's methamphetamine. If you're in the West or the South, or if you're in the mid-Atlantic, like you guys are, maybe it's cocaine, but it's a high-potency street stimulant. Well, again, you've got a much higher dimension 5 relapse risk, also not just in terms of the risk of relapse, but in the dangerousness of the relapse, because daily methamphetamine use, daily cocaine use has a very high level of imminent danger for a young person. And so here's a setting in which the balance for me is tipped to residential treatment rather than intensive outpatient treatment. I list number 2 here, start her on a relapse prevention medication, because unfortunately, as you probably know, unlike for OUD, we don't really have great relapse prevention medications that have high potency and high effectiveness for stimulants the way we do for OUD. So I wish number 2 was an option, but unfortunately, we just don't have the medical technology yet. And so in the absence of good relapse prevention medicines, we're relying on psychosocial treatments, on counseling and therapy and the like. And so again, I think that tips our hand to a residential treatment placement. All right, so back to our original placement. She's been going to the original outpatient treatment placement, and she misses several days during the second week of the program. Not like in that high severity scenario where she ran away and never showed up. She's been coming, but week 2, she misses some appointments. She says this past weekend, she used some cannabis, some alcohol. What do we do about that? And here, I think that the key is how far from your original formulation and conceptualization of a treatment plan has she strayed? Does this ruin the possibility of success of an intensive outpatient treatment placement? Or, as I would say, not necessarily. I would say, listen, she's been coming, maybe not perfectly, but you're beginning to get engagement. Furthermore, she's being honest with you. She's not lying and pretending that she's not using and she doesn't care about treatment goals. She comes in and she says, listen, I want you to know that I did use, and maybe she's even asking help about that. All right, well, that's a very good prognostic sign. So here, maybe it's keeping the same level of care, but changing elements of the treatment plan, but certainly encouraging her in her motivation and debriefing it by praising her honesty, not cutting her head off because she used. After all, you're playing the long game. You don't expect people to be committed to abstinence from day one, and see if you can continue on the path of progressive engagement. Now, if this keeps going, and a month later, or 2 weeks later, or 3 weeks later, I don't know what the magic number is, but she's missing more days than not and using more days than not, well, now it looks like your initial formulation of a successful course of treatment in intensive outpatient may need to change to something more intensive. And here, although you could certainly try to alter the treatment plan in the same level of care, I'm not against that, but if you've been trying that and here we are week 3, week 4, whatever, and she's still not coming as much as she ought to or at all, then it's time to increase the level of care, perhaps by referring to residential treatment. She doesn't show up at all. And grandma says, I can't make her come. Well, you could refer her to residential treatment, and if you can get her in, that's reasonable. But will she go to residential treatment? Unclear. So part of that is understanding what your leverage points for engagement at all are. Sometimes juvenile justice involvement can exert the appropriate leverage to get somebody into residential treatment as a young person who doesn't really want to go, but if told they have to go, will go. If your juvenile justice system is anything like mine, this is less and less of interest to probation officers and juvenile justice authorities. This has changed over the past 5 years, 10 years, as it's becoming less interesting or of interest to juvenile justice agencies to use residential placements. They've increasingly had the idea that, well, cannabis is not such a big deal anyway. We don't want to be in the business of enforcing behavioral change for cannabis through through juvenile justice sanction. So you might have some difficulties here, and it's increasingly hard to know how to engage these hard to engage young people if juvenile justice won't step up. That's my view, not that they always ask me. And if you can't figure out a way to leverage grandma's persuasion. But those are the things you're going to try to do. And I see that we're kind of getting out of time. Do we have a hard stop at 3:30 if somebody can answer, or should I continue for another 5 minutes?
Yeah, I think you'll be okay to keep going for another 5 minutes, Mark. And then if people need to log off right at 3:30, they can, and it won't affect them at all.
Okay, fair enough. Here's an alternative scenario. She does well. She's mostly abstinent or gets abstinent after some time. She's attended some 12-step meetings based on your encouragement. And lo and behold, she's surprised. It's not as stupid as I thought. I could try that again. What should you do? Should you say, well, she's done, she's finished, she's fixed, she's baked and ready to come out of the oven, let's discharge her? She doesn't need this level of care anymore? Should you keep going but praise her and encourage her because she's come so far but has further to go? Should you try to be responsive to her progress by decreasing the intensity of the program requirements, say stepping her down from this many days a week to fewer days a week, or stepping her down from intensive outpatients to regular outpatient? Or let's say she's on probationary mandate or sanction or restrictions, either with the probation officer or with grandma. Can you get them to give her some incentive by responding with what she sees as a reward? This is an important distinction, and it puts us sometimes in a vexing position because we think of the intensity of treatment as a good thing, but you should remember that young people typically think of the intensity of treatment as restrictive and a bad thing, and they can't wait to have less rules, less intensity, less requirement. Well, we may not see it that way, but since we know they see it that way, we should consider the possibility of using their currency to reward them for good progress and good treatment response by giving them something of what they want. So that's a consideration. All right, so summary. The 6 ASAM criteria assessment dimensions are helpful to guide treatment and placement. So just the notion of taking your assessment material, what happened when you were 12, what happened when you were 13, what happened last week, and organizing that, not just in historical sequence, not just by content area as we started, drug, school, family, work, but now organizing it by the 6 ASAM assessment dimensions. That's a useful tool for organizing information about assessment severity, correspondingly treatment needs, and then correspondingly about who goes where and treatment matching who needs what. As I said before, treatment engagement is the place I recommend people start. So dimension 4, even though it's not numerically at the beginning of the list of assessment dimensions, is really where the rubber first hits the road and really is where we need to spend most of our effort, because young people are not very motivated at the door and need the most work on enhancing motivation. Be flexible. You may not get it right the first day or the second day or the first week or the third week, but if you keep at it and always have a plan that you're willing to modify based on how it goes, and you with therapeutic optimism, you're much more likely to succeed, and it's a long game. And here's the hypothetical miracle cure, right? If only we could give them new brains, and if only we had brain transplants for adolescent substance users with co-occurring disorders as an outpatient procedure that we could do in the office, right? But I say that facetiously on the one hand, but it's also actually partly true, isn't it? Because if you keep them alive long enough, many of them do actually grow up. Many of them do mature. Many of them do get so-called new brains just by tincture of time and relationship with you as a caring, supportive adult. So although this is in some way a science fiction fantasy miracle, it's also really what happens if you can go the distance, run the marathon, it's a marathon, not a sprint, and continue to work with patients and their families. So I'll stop. Happy to hear from folks, and thanks for your attention, and have a great rest of your day.